Greetings, my name is Brad Monk. I'm a gynecologic oncologist from the University of Arizona Cancer Center in Phoenix. I'm coming to you from Tampa, Florida at the 45th Annual Society of Gynecologic Oncology. It's my privilege to bring to you Professor of Radiation Oncology, Wui-Jin Ko. Welcome, Wui-Jin.
Thank you, Dr. Monk.
Thank you. You can call me Brad. I've only known the guy for 20 years, and he calls me Dr. Monk. Let me tell you, Dr. Ko, Wui-Jin, has been the co-chair of the Cervical Cancer Committee for the GOG for 12 years. He has been a major contributor and perhaps even the thought leader in the way cervical cancer patients are treated in this country, but as well as around the world. So this is a first time that he's been with us. His perspective is going to be very, very important. We're going to begin in an area that maybe he's not quite as familiar with, but I think he's committed to it because it's about screening. Remember, cervical cancer is completely preventable through vaccination or screening, and the current screening paradigm is to begin at the age of 21 and to use a Pap test every other year, and ultimately when a woman turns 30, to do Pap testing and HPV testing right from the cervix, what we call co-testing, because over 99% of all cervical cancers are caused by HPV. At this meeting, it's changed, okay? The way cervical cancer is screened is over. It's a new world. And last week, the FDA voted to recommend approval of the information that was presented at this meeting. Tell us about Athena. Athena is the name of this very pivotal clinical trial presented in the first session here.
Right. So it's a very large trial with about 41,000 evaluable patients who screened via a range of mechanisms. Of course, the historical one was using Pap testing, but the others included Pap testing with co-testing with HPV, or several regimens that use HPV testing as the primary modality for screening, for selecting patients who would otherwise be deemed low risk or no risk and can go on to routine screening after that, or to select them for colposcopy. So, as you know, the concern with Pap testing historically has been the inconsistencies of the reading, the processing, the interpretation. So there have been a lot of interest in looking at HPV-based testing to really select the patients who are at risk for neoplasia. So the Athena trial, and I have the list in front of me, again, looked at liquid-based cytology as the, if you will, the standard control arm with reflex HPV testing, and compared that to co-testing and 3 additional regimens where HPV was used as the primary screening mechanism.
Wow.
And the ultimate...
Let me just digest that. So took what we used to do, Pap testing, going to confirm co-testing Pap and HPV together, but really looked at other modalities where the HPV test is the driver. That would be the death of the Pap test.
Well, not completely, because the arm that was arguably the best, and best is a combination of sensitivity and specificity.
You finding precancer, CIN 2 or 3, high-grade dysplasia, carcinoma in situ.
That's right.
Keep going.
And they measured specificities as the number of colposcopies required to diagnose one of these, pre-invasive cancers. And so their conclusion was the one that gave you the best combination of sensitivity and efficiency was doing HPV as primary testing, but
without a Pap.
Without a Pap, but to then use reflexive HPV genotyping and cytology as a secondary triage.
So you do the Pap and the cytology, but the cytology is only read under certain circumstances.
That's correct. So if the HPV is positive, so the argument would be if the HPV is positive for 16 and 18, which is the highest risk types, they go to colposcopy regardless of what the cytology is.
The Pap's not read.
The Pap's not read. But if they are positive not for HPV 16, but for 12 other high-risk subtypes, then they do triage to a Pap smear or cytology. And if the cytology shows atypia, ascus or above. Then they go on to colposcopy. So we don't completely get rid of cytology, but it is used as a secondary, if you will, screening mechanism. And the sensitivity is much better when you flip it around compared to what we traditionally now do.
This is a breakthrough. So we have, the current recommendation is when you turn 30, you get a PAP and HPV test together. And you read the PAP every time. So now, if I understand you, if the HPV test is negative, throw the PAP away.
That's correct.
5 years. We'll see you back in 5 years for a cervical cancer screening. You still need to see your doctor every year. If the HPV test shows 16 and 18, since those are the highest risk types, throw the PAP away and do a biopsy, colposcopy as you call it, and you only do a PAP if you have 12 of the other high-risk HPV types associated with cancer.
The non-16, non-18.
Non-16, 19, 12. I love it. And the FDA voted on it last week and said, we love it.
That's right. Well, the advisory panel suggested,
okay.
and I guess we will hear over the ensuing few weeks whether the FDA, which we hope, accepts that. And I think it will be a step forward because it's clearly much more sensitive than using our historical cytology with reflex HPV.
I love it. It's game-changing. And so I think this was the Roche HPV test, and there are other, BD, Hologic, Wui-Jin, there are other HPV tests. So my wish, my vision, is that there'll be all these HPV testing options, and that'll drive the price down.
Sure.
I love it. I love it. All right. So screening, vaccination, that's the key. You and I are therapeutic oncologists. I'm a gynecologic oncologist. You're a radiation oncologist. Generally, most cervical cancers are small lesions. I take care of them. I do a radical hysterectomy, remove the ligaments, the perimetrium, upper vagina, and the lymph nodes. But there are some patients that I refer to you for radiation after radical hysterectomy. Tell us who those patients are. Who needs radiation after a radical hysterectomy?
Right. So after radical hysterectomy, there are a spectrum of risk factors. And I sort of divide them up into uterine confined versus, or cervix confined versus extracervical risk factors. So the standard of care for the cervix confined spectrum of risk factors, that means the disease is still within the body of the cervix, are what we call the intermediate risk factors. And it's a combination of tumor size, depth of stromal invasion, and the presence of lymphovascular space invasion. And essentially, while there's a kind of a complex model, you need 2 of those 3 risk factors in the context of negative nodes, all right?
To get radiation.
To get radiation. And the standard of care, based on the GOG 92 study in this day and age, is for patients to get post-operative pelvic radiation.
What do you mean by pelvic radiation? Brachytherapy in the vagina? What do you mean?
It's external beam radiation. Brachytherapy was not used in GOG 92.
Okay.
And that study showed a significant improvement in progression-free survival. It did not quite reach an overall survival improvement, although the P is 0.08, and one recognizes that was an underpowered study. But that has become our standard of care, that after radical hysterectomy with intermediate risk factors, i.e. node negative, but with a combination of tumor size, depth of stromal invasion, and lymphovascular space invasion, that those patients, if they have 2 of those or more of those risk factors, would benefit from adjuvant external beam pelvic radiation.
And is this the same sort of radiation port that you would use in rectal or prostate cancer, or is it different?
No, the radiation for cervical cancer tends to be more generous. For rectal cancer, you limit yourself. The external iliac nodes are not considered at risk. So you tend to limit yourself to more of the posterior pelvis. For cervical cancer, and for prostate cancer, there's even a debate of whether the nodes should be treated. Many people with prostate cancers don't have their nodes treated. I mean, there are all, different models where if there's a combination of high enough risk factors like Gleason score and stuff, that they might include nodes. So prostate cancer doesn't include nodes. Cervical cancer, you typically will include all the pelvic nodes, the external iliacs and maybe the low common iliacs, all the perimetria. So it's a little bit more generous volumes that have historically
And how
been.
far down in the vagina?
You want to treat at least 3 to 4 centimeters of the vaginal tract.
And how high?
And in GOG 92, the recommendation was to go to the L4, L5 interspace, and that's a little bit anachronistic, right? In terms of looking at skeletal landmarks. The idea is to treat all of the external and internal iliacs up to the bifurcation of the common.
And what dose?
And the dose is 50.4 gray and 28 fractions.
I love it. So we're trying to add chemotherapy to that because that's just radiation alone. It's unproven. That's a GOG study, GOG 263. Just what you said, the cervical risk factors, 2 out of 3, radiation versus radiation chemotherapy. That's GOG 263. Now, what do you do if it's in the lymph nodes?
Right. So the other group for which you've undergone successful radical hysterectomy is what I call extracervical disease, all right? And so the 3 pathologic findings that have been used to select for additional treatment is positive nodes, as you mentioned, positive parametra, or positive margins. So I have interpreted that as saying that the disease has left the cervix, right? Because either nodes, the parametra, or if you have positive margins, it's either positive paramargins or positive vaginal margins. So it's gone beyond the cervix. And in that patient population, the standard of care, as again established by a GOG intergroup study, is chemotherapy and radiation. So you've upped the ante here. You're no longer talking about an intermediate risk. These are called high-risk postoperative patients. And so the standard of care is pelvic radiation. The dose and the fuse are pretty much similar, 50.4 gray and 28 fractions. But that is given together with concurrent cisplatin containing chemotherapy.
Now, when we give chemotherapy with locally advanced disease where radical hysterectomy is not possible, and those patients now also need brachytherapy, intracavitary brachytherapy generally, because I give the chemotherapy, we generally give 40 milligrams per meter squared of cisplatin, not carbo, 40 milligrams of cisplatin every week. Try to get 6 in, but if you only get 5, it's okay. And we cap it at a BSA of 1.75, which is a total dose of 70.
That's correct.
But in this post-radical hysterectomy node positive situation, the study didn't use weekly. So do I use weekly like I do with advanced cancer when the nodes are positive after radical hysterectomy, or do I use the other regimen, which was really 75 milligrams every 3 weeks?
You know, that you raise a good question, because I think that when we say cisplatin containing regimen, there are really 2 options.
Okay.
One is to use the weekly platinum at 40 milligrams per meter squared, as you said. The other option is to use a higher dose of platinum every 3 weeks, but that has to be combined with 5-FU. So the specific study for node-positive disease was actually 5-FU, 1 gram per meter squared per 24 hours for a 96-hour infusion, plus platinum at a dose of 75 milligrams per meter squared every 3 weeks. And that was actually given both during and after radiotherapy, which has, raised some questions about the effectiveness of further chemotherapy that we'll be discussing later. But in sort of generalizing the impact of platinum-based chemoradiation, I think the community, the GOG, has argued or postulated at least that whether you give weekly platinum at a dose of 40 milligrams per meter squared, or you give the tri-weekly platinum, if you will,
with 5-FU.
With 5-FU, that is the most important component of that is the platinum, and that you get the same overall dose of platinum. And so right now, many people will say that even though that specific regimen wasn't tested for node-positive disease, many people would feel comfortable giving 50 gray with 5 or 6 cycles of weekly platinum. It's an extrapolation from other, platinum-containing regimens.
And I've spent a career trying to teach people that cervical cancer is a chemotherapy-sensitive disease. When I joined your committee, your cervical cancer committee on the GOG, it was thought of being a resistant disease. So many people are talking about adding more chemotherapy. in the node-positive post-radical hysterectomy setting, or also in the locally advanced, can't do a radical hysterectomy, the stage 1B2 to 4A. Tell us about that strategy, adding more chemotherapy.
Sure. So one goes back to the node-positive post-rad his, as we talked about. That did actually give, the protocol was to give 4 cycles of chemotherapy on a tri-weekly basis or on an every 3-week basis with 5-FU cisplatin, 2 during the radiation and 2 after. And as an exploratory analysis, it was not stratified for, but it was a post hoc analysis. There was a suggestion that if patients got 3 or 4 cycles of chemotherapy, they had better oncologic outcomes than if they only had 2. So,
I hate that analysis. So the sicker patients that couldn't get chemotherapy did worse. Keep going.
Right. I
keep
get
going.
it, and that was a point of contention, right?
Keep going.
But in a meta-analysis, there was some other studies that suggested that, as you pointed out, with the recognition that cervical cancer is not as chemo-resistant as we once thought it to be, that whether we could add further benefit, both in the node-positive post-radical group, radical hysterectomy group, or in the advanced cervical cancer where you don't do surgery at all. Because we realize that after you give chemotherapy and radiation, the predominant pattern of failure is distant.
Exactly.
And so it doesn't matter how good surgery you do, and you all do good surgery, or it doesn't matter how good radiation we do, those 2 modalities are not going to impact the distant metastasis. So we're now studying in both the node-positive group, post-radical hysterectomy in RTOG, GOG 0724, and in the Outback study, the role of additional chemotherapy after completing local regional therapy with chemoradiation.
And the additional chemotherapy
is 4 cycles of carboplatin and paclitaxel,
right.
Because that was felt to be, even though that regimen was not specifically tested, it was felt to be a well-tolerable regimen and well accepted by practitioners and patients alike.
So again, to the point, I and you and others have been working on chemotherapy and cervical cancer for many years. Published just last month within the New England Journal, GOG 240, that shows that in the metastatic setting now, incurable patients, that bevacizumab can be added to chemotherapy, that it can improve survival, and that these patients can live over 1.5 years, and that the response rates are over 50%. Okay, GOG 240, and I'm pretty confident that will be the first label of bevacizumab in a gynecologic cancer. So adding chemotherapy and bevacizumab together in the metastatic setting. So at this meeting, they did some analysis of some of the prognostic factors in that metastatic recurrent setting of this GOG 240 study. Tell us about that.
So the prognostic factors, which has sometimes been referred to as the Moore criteria, because Dr. David Moore and you had worked on that, looked at 5 individual factors that may predict or prognostic for worse outcomes, and those are
in the setting of recurrent disease.
In the setting of recurrent disease, who were then going to go on to get chemotherapy.
So if you have these, it's bad. Go ahead.
Right. And so they were African American race, exposure to previous platinum chemotherapy, which we now know because everybody gets chemoradiation. The majority of people who fail now have had platinum. A performance status of 1 versus 0.
Disease in the pelvis.
With disease within the pelvis and a progression-free interval of less than a year. And so there were these 5 individual factors. But to gain even greater discrimination, the Moore criteria combined them into sort of a low, intermediate, and high risk, where the low risk, or the best performers, if you will, were those who only had one of these individual characteristics. And the intermediate risk group had 2 to 3. So the low risk was 0 to 1, intermediate risk was 2 to 3, and the high risk was 4 to 5. And what Dr. Moore had previously shown was that those were very prognostic for outcome, and also in many ways predictive for outcome following cytotoxic chemotherapy in the recurrent metastatic setting.
So I spoke with Tom Herzog about a training set and a validation set. So that was kind of a ad hoc sort of thing in the last iteration of clinical trials. Today, though, they validated it. So those same criteria, they're still relevant?
Yes, and this was prospectively evaluated in GOG 240.
The bevacizumab
trial. And what Dr. Tawari and his colleagues found was that they're still relevant as prognostic factors. So they do categorize or distribute
I noticed
patients.
You didn't use the word predict. Keep going.
Yeah, you can see I'm struggling a little bit with that predicted. So
they categorize.
So they categorize or they differentiate patients into prognostic groups. Right. So yes, they still carry an important prognostic element. However, I think what was very interesting in this analysis is that they're not predictive. Right. Is that even though you can argue that the high-risk group did overall worse than the low-risk group per the Moore criteria, you couldn't predict for their response to a bevacizumab-containing regimen. And in fact, if one looks at the hazard ratios, one could actually make a case that the people who benefited relatively the most based on hazard ratios were the ones with the highest risk, the sickest.
So that's a completely different thing than what the training set had showed. The training set had showed, yes, they're prognostic, and if you give them chemotherapy, it's not going to work. Right. Now, in the prospective validation, it shows, yes, it's predictive, but those patients that are the worst, you can still help. Why? Because you have better chemotherapy. And in the current era, you have chemotherapy plus Bev. I really think this is an important concept for our listeners and for the clinical world to understand.
So what I would say is that, yes, the Moore criteria retains prognostic information, but it is not predictive for benefit.
Right.
It is not predictive for benefit in this day when we have better chemotherapy, including, in this particular situation, an anti-angiogenic capability.
Listen, Wui-Jin, it's been my honor to have you. I want to personally thank you for your commitment to women with cervical cancer. You have been, as I already mentioned in the beginning, an introduction, one of the world's leaders in this field, taking time away from your busy schedule to be here with me today. This has been Best of the Day, 45th Annual Society of Gynecologic Oncology in Tampa, Florida. Thank you for being with us, and so long for now.